Good afternoon, and welcome to the panel on health data in Canada. My name is Grant Robertson. I'm an investigative journalist with the Globe and Mail. Health data are essential. This is not a new insight necessarily, but discussions about health data are now much more widespread as a result of the COVID-19 pandemic. Case counts, hospitalization rates, and epidemic curves are now common currency in everyday discussion. Equally, there have been conversations about the data that is missing. This includes data about race, occupation, and socioeconomic status, and how lacking such data harmed our understanding of how the pandemic spread early on and its impacts on communities. In June, the Pan-Canadian Health Data Strategy Expert Advisory Group released its first report looking at these issues. The report is not only a detailed breakdown of the challenges, it also outlines the need for Canada to modernize its health data system while still navigating the treacherous world of privacy and data stewardship. I'm pleased to be joined today by 4 top experts in this field, including several who are part of the Pan-Canadian Health Data Strategy. Joining me are Dr. Vivek Goel. Dr. Goel is President and Vice Chancellor of the University of Waterloo and a professor in the Schools of Public Health Sciences and Pharmacy. He also chairs the Expert Advisory Group on the Pan-Canadian Health Data Strategy. Dr. Arjuman Siddiqui. Dr. Siddiqui is Professor and Division Head of Epidemiology at the Dalla Lana School of Public Health at the University of Toronto, where she also holds the Canada Research Chair in Population Health Equity. Dr. Jonathan Dewar. Dr. Dewar is the CEO of the First Nations Information Governance Centre. He is also part of the expert panel working on the Pan-Canadian Health Data Strategy. And Dr. Kim McGrail. Another member of the panel, Dr. McGrail is a professor at the Center for Health Services and Policy Research at the University of British Columbia. She is also Scientific Director for Health Data Research Network Canada. Welcome to you all. Vivek, I'll start with you. As chair of the Expert Advisory Group, what has the COVID-19 pandemic shown us about the state of health data in Canada and where the gaps and challenges are? And where do you see the most pressing need for action?
Well, thanks, Grant, for chairing this panel, and thanks to the Royal Society of Canada for organizing this. It's a very important discussion for us to have. As you noted in the introduction, we saw so many gaps in data throughout the course of the COVID-19 pandemic, and we continue to see them. I'll just highlight a few examples. At the very start, we were very limited in the basic case data. You mentioned descriptors like employment status or place of outbreak. I know Arjuman will talk further about the need for socio-demographic and equity indicators. We also did not have very timely death data. And even in the news very recently, there's still issues around classification of deaths being inconsistent across health units or regions of the country. And how that, you might say, well, how important is some of that data? They're trailing indicators or so on. But if we think of something as simple as occupation and place of work being there in the case record, it will help us in knowing where the disease is spreading and where we need to take actions. In the absence of that kind of granularity in our data about where it's spreading, we were left with taking blanket measures like province-wide or region-wide lockdowns. We also didn't know about which populations were being affected the most. If we think about clinical data, how many people were in ICU, how many people have to be on respirators, how many people are getting different types of treatments, what their outcomes are in a timely manner, and how that relates to the exposures that they had. When we got the variants coming out, there's a reason why the variants keep being picked up first in the United Kingdom, because they have very robust surveillance systems that link public health, clinical services, genomic sequencing capacity, and research that brings the data together in a very timely manner and allowed them to pick out the patterns for variants, as well as identify variants of concern very quickly. In Canada, we've been doing a lot of sequencing, but we've had challenges in sharing that data and making it available at a local level, at a national level, and at a global level. And even now, as we think about the vaccines and the rollout, the issues we've had in keeping track of how many vaccines are given, who's getting them, which groups are getting them, developing things like our vaccine certification systems, the vaccine passports. Why have we wound up with multiple systems across the country rather than a single system? You mentioned the privacy concerns, and I'll give one other examples. Early on, there was a lot of focus on contact tracing apps, right? And we could have had contact tracing apps that would have been more meaningful and perhaps would have been adopted more. But because of concerns around privacy and using things like GPS data, we wound up with what I would describe as a very watered down version of the app. And it wasn't adopted uniformly across the country. And when we think about it, we could have rolled out applications that would have had a degree of personal control over information and allow people to make more informed choices. And I think if we went to people and said, would you rather continue to have lockdowns, or would you be prepared to share some of your information in order to prevent lockdowns? The vast majority of Canadians would probably go with the latter. And so that gets me to what our expert group has been working on. And these challenges that we had with data during COVID-19 were not new challenges. We've known about these challenges for decades. And in fact, in our first report, as the background for that, we summarized 60 years of reports on health data in Canada. And we have two quotes in there, one from Martin Wilk report 30 years ago, he was chief statistician, another one from David Naylor's inquiry after SARS. You could take the language from those reports and describe the situation we have today. And why is it that we don't seem to be able to succeed? We've got a number of barriers that we identify in the report, and I'm certainly happy to come back to these. But the key thing is that we tend to jump immediately to looking for technological solutions. And we think, okay, we just have to get someone to build a new system or to buy a new system. And we focus on the next big shiny thing. And after SARS, we had a big commitment to building out a vaccine surveillance system for the country, and this commitment to buying a particular product, Panorama from IBM. And then, to put it bluntly, we did not execute well on its implementation across the country. And the reason we didn't execute well is we didn't pay attention to the fundamentals. And the fundamentals are actually thinking about how we govern our data systems, how we make the shared decisions, how we engage the community, how we can engage the public. And Jonathan will speak to engaging First Nations. We need to bring the community into the conversations and have these kinds of conversations. Would you like to see your data being used to improve health for you? Here's what needs to be happening. And use that to design the governance of our systems. Similarly, we have to start by looking at our policy frameworks. Our policy frameworks for health data are based on what I would describe as an analog model. We go back to paper records, and we had health information custodians. We had people had custody of the records. It was the provider that gave you services, a hospital, a physician, a clinic. And if you wanted your record, you went to get it from the custodian. We now work and live in a digital age, and you don't have physical records. You have digital records, which can be moved around and copied, but we still have this concept of health information custodians. So we need to move our policy framework to a modern digital era as well. I'll pause there and happy to come back later in discussion on any of these points.
Those are some great points that we should come back to. It's fascinating to hear you talk about the challenges there because, I think as society, we've become so accustomed to the idea that, in the business sector or commercial enterprises are collecting our data and have so much commercial data on us. I would have assumed before COVID-19 that, our health authorities had a lot of data on my community and, potentially could use that data. It's a real eye opener what you're saying there. Let's move to Jonathan. Jonathan, the First Nations Information Governance Center has created a national data governance strategy for First Nations communities. I wonder if you can talk about what the data challenges are for these communities and where you want to take that strategy and what needs to happen for it to be implemented.
Thanks, Grant. And so I get the rest of the hour to do that, right? So, I mean, in 5 or 6 minutes, I won't be able to touch on all of it. I'll do a couple of topics in your question, and then I have time to loop back. First, hello to my fellow panelists and to an audience that I can't see, and I hope it's a large audience, though it's certainly less daunting to talk to 5 of you or 4 of you. I'll start with the caveats I warned you that I would start with. So as you indicated, the organization I work for is called the First Nations Information Governance Center. So I'm speaking about First Nations perspectives. And it's important to note that Inuit and the Métis Nation need to have the same opportunity to speak to their work and of course to their aspirations. And so I'm going to get a lot of space to do that on behalf of First Nations today, but I do people that Inuit and Métis Nation also need to be afforded those spaces as well. The other thing I need to say is that the First Nations Information Governance Center is a strictly apolitical technical organization. So I'll be speaking from those perspectives. We serve First Nations, but it's rights and title holders and the leadership of First Nations that can speak to these issues from the highest level, the idea of governance in terms of the nation-to-nation relationship that First Nations are in with the Crown, Canada, all the way down to the information governance components that we may talk about today. So you referenced a First Nations information governance strategy, a national strategy for First Nations. This is not a new development. Certainly the delivery of the strategy is relatively new, but the conversations are actually decades old. Our organization grew out of work in the mid-1990s, responding to some challenges that had to be turned into opportunities. That led to what is now the long-standing national survey that we refer to as the First Nations Regional Health Survey. So we're in the health information business, analyzing that information that comes in from this by First Nations, for First Nations national survey. But I won't claim that we have cornered the market on all things health information. We have many First Nations partners and non-First Nations partners working with us in these areas, and my colleagues are experts in some of the areas that I won't be able to speak to, which is the richness of this panel for sure. So that nearly 25 years of work doing this national health survey has been alongside the other piece of work that I think people know us by, which is as the stewards of what we refer to as the Ocap Principles. And so these are the principles of ownership, control, access, and possession. And I talk about it in terms of principles. And the important distinction for people to understand is that we do need to approach these as principles that need to be upheld by First Nations themselves. They need to assert these things, but also upheld by those we work with or those who would deign to work with First Nations. And so ownership, control, access, and possession as principles is where we start, but it's rights and title holders who can define and implement ownership, control, access, and possession. Now, how do First Nations do that? How do they assert these rights? And it's not just about the rights of the individual, it's also about the rights of the collective. So if information identifies a community or a First Nation, it is, from the perspective of First Nations, the right of that collective, that community or that nation to own, control, access, and possess that information. Unfortunately, Canadian law, and Vivek made reference to issues of privacy, and I think that'll be a topic of conversation. Canadian law doesn't adequately support the assertion of collective rights for First Nations. So that's a big component. It's part of why we do the work that we currently do in this narrower lane that we're in. Where that lane stands to get bigger for First Nations, and ideally FNIGC in support of First Nations, is with this national data governance strategy. And so to put it in a nutshell, it's complicated, but to put it in a nutshell, what we have proposed is the creation of what we refer to as regional information governance centers. So one in each of our 10 regions, able to serve the unique needs of nations and communities in a region. And then that network of regional information governance centers coming together to continue, and of course, to grow the work that we can do nationally, work that is best done or necessarily done at a national level. And so those are important distinctions because, of course, rights and title holders are at the nation level, or at the community level. But we do come together in ways out of necessity, and those of you who are data folks will understand the need for populations to come together to have a size of a population that makes certain types of work possible. So the strategy is all about those elements. It's about ensuring that we can put capacity into regions to support the needs of leadership in a region. So the first piece of work that we'll be doing with funding from budget 2021, so the very recent development, budget 2021, there's a significant amount of money in the budget for FNIGC and its regional partners to advance phase one of what we proposed in our 2020 strategy. So that will see support within regions, dedicated capacity within regions to support leadership to resolve on the information governance regime that they need to create at a regional level, to work with partners from the ground up through the various levels, including the federal. So with each of our regions is able to establish that information governance regime, the next component of the work we'll try to do in this phase one is to assess what community needs are and what the aspirations are for a regional information governance center, or what we might say is a statistical institution to serve the needs of First Nations in a region. And again, as a network, we would then be able to have that institutional footing at a national level. And so what are the challenges? Well, the biggest challenge is Canada built a broken system. And if, as Vivek said, it's not serving Canadians as well as it could because of all kinds of reasons, including jurisdictional issues, that is exponentially worse for First Nations. And I can say for Inuit and Métis Nation citizens as well, because of course they've shared that with us publicly. So it's exponentially worse for First Nations populations. And so there is a need to address all of these issues, from the big picture issue of what is the relationship between First Nations and the Crown, what is the Crown's responsibilities, what is that federated system that the Crown has built, what can it do to support First Nations as sovereign nations in building up the capacity that we need to be able to do by First Nations for First Nations approaches to these issues. And this is something that a number of people probably heard me say, and my colleagues say over time, is as we build up these First Nations institutions, it's not about tearing down Canadian institutions, but it is about ensuring that those Canadian institutions can pivot to be the best partner for First Nations institutions. And I think my Inuit and Métis Nation colleagues would say the same thing. And so that's really what we're talking about. And to Vivek and our colleagues on the Pan-Canadian Health Data Strategy group, to their credit, they created the space for us to have those conversations and included this kind of language in that document. And so I'm excited for where we can go, and I'll just loop back to underscore the point that it won't be an FNIGC, a technical apolitical organization, leading these conversations, but it will be First Nations speaking with Canada. And sometimes, we'll be excited about what we're building together, and other times there will be quite pointed messages, like the fact that Canada needs to get its house in order on a number of fronts. It can't be First Nations fixing those issues. Canada needs to do that, and that means provinces and territories within that federated family have to be part of that conversation and part of the solution. So that's as provocative as I'll get right now. Thanks for the opportunity.
Two of the words that really jumped out at me that you mentioned there, ownership and control. It almost seems like in this digital age that we live in now, this data age that we live in, that those are two of the words that hang over everything. Trusting and being able to control how your data is used, but also having that data available so that in times of need, for example, like a pandemic, that health systems can respond, but the communities that are giving up their data aren't being taken advantage of. That is a great transition over to Arjumand. Arjumand, you've talked about data availability and data access, and those being two key challenges facing health data in Canada. And you've mentioned before the tension you see in there as a result of these issues. I wonder if you can elaborate on that and how it translates into some of the real world problems that we've seen during COVID-19.
Sure. Thanks so much, Grant. And thanks to my fellow panelists. It's really a pleasure to be here. I sort of want to say just ditto to Vivek and Jonathan and just call it a day here. But it is worth saying one thing up front, which is I think my colleagues have much more expertise in terms of dealing with data infrastructure. And so as I speak, it's probably worthwhile thinking of my perspective from a user end. More than someone who has expertise in infrastructure. So that's the sort of premise of all of this. I really do want to echo what Vivek said about the basic data scaffolding and how shocking it is that we don't have some of the basic things that you might anticipate we do. And I think where I'll sort of add to what he said is, as you said, Grant, from the sort of accessibility and availability perspectives. So as I see it, there are multiple conversations happening right now in Canada about health data. Those conversations have to do with important governance control issues like the ones that Jonathan talked about. And in what Vivek said about the fact that we don't have some basic forms of data and we don't have sort of sharing and so on in the way that might be most useful, I think there's a couple of things tied up in that. One is whether or not we're collecting the data that we need. And Vivek mentioned that I would talk a little bit about socio-demographic data. And so let me just give you an example from COVID-19. At the outset of the pandemic, we started to see a couple of things happen at the same time. One was that here in Toronto, there were local news reports about the people who seemed to be dying. And by and large, these were Black and brown people, largely women at the outset, largely people working at long-term care facilities. And people started to comment on the fact that there seems to be this racial pattern to the pandemic. But we didn't have any data to verify whether what we were seeing on our TV screens as a case here and a case there was actually a systematic pattern. At the same time, though, we saw reports from the US where data on many of the COVID-19 indicators plus data on demographics like race were readily available to scientists. And so you saw a plethora of studies and various types of information being produced very rapidly in the US on racial inequities, for example, in COVID-19. And we just couldn't do that because we simply did not collect that data. We didn't tether it to our health data and so on. And in fact, there was political resistance to doing this. So as communities started to say, look, I think we need to know what's happening. And as Vivek said, who's being most affected. And it looks like there might be a racial pattern. Very early on, there was a lot of political resistance at the provincial level to doing this. And eventually that worked itself out. I'm not sure exactly how that conversation went, but it worked itself out eventually. But there's still issues in accessing that data. And the issues have to do with how readily you can obtain the data that's now being collected. So on the one hand, the access and availability has to do with the fact that we weren't collecting it at all. Then we started collecting it. And I can tell you as someone who's tried to access it, it took us almost 1 year to get the data that had been collected. Now, we can have a discussion about whether actually we need to be very vigilant about who gets a hold of the data, what processes they go through, and so on and so forth. And I think that is a big part of the conversation in Canada right now. Things like privacy, governance, control, et cetera, are a big part of the discourse around demographic data collection and health, as they should be. But I suppose the counter, or if it's not the counter, the complementary perspective to offer is that once you collect that data and you've done it with some governance processes that you're comfortable with, I think Canada has to think long and hard about how how much of a barrier it is to actually get access to data in a timely manner, in a way that scientists can use it to produce evidence quickly, to be nimble, and so on. And I think, Jonathan and Vivek, and I'm sure Kim will say this as well, will point out to you that these are not new issues. These are issues that are longstanding. And I remember when I returned to Canada in 2010, a bunch of social scientists said to me that they don't study Canada because it's just a pain to do it, because you have to go to the Statistics Canada Research Data Center, and you have to do that between 9 and 5. And that's just not how a lot of scientists work. They, analyze data in the comfort of their own home at 2 o'clock in the morning. And so, or they may do that. And having gone through that research data center process to get access and so on, I can tell you there's issues with international collaborations because you can't take the data out until you really know. And I mean, there's just all of these sort of procedural issues that are intended, I think, to maintain a lot of control and privacy, which makes sense. But I worry a little bit that the balance is skewed so heavily, and the conversation is skewed so heavily on that we're missing out on how well that data can actually be used to produce evidence. And so if another quick example for you, we did a study some years back. We were asked by the government of Ontario, the former administration, to look at the health effects of social assistance programs. And so we said, well, we'll look at it for Ontario, we'll look at it for all of Canada, we'll look at it for some comparator countries, the UK and the US. And sitting in Ontario, studying other countries and studying our own, it was most difficult to access our own country's data. We could, sitting in Canada, access the UK and the US with total ease over the internet, no problem. But accessing our own data to study this question was fairly challenging. And so it's just another thing to add to the discourse. It's important to think about issues of control and so on. I don't challenge that at all, but I do think we need to think long and hard about how much of a barrier it is to access data, to then have Canada produce evidence and participate in both sort of domestic discussions and international discussions on health issues. And I'll leave it there.
Those are great points. It makes me think of, as you talked about, sort of the upside versus the downside. And if we can, anonymize the data and make it usable for researchers without presenting a privacy downside, that would be the solution. But that seems to be the big question here as to how we get there. Let's go to Kim. Kim, we've been waiting patiently to talk to you. You've talked about the importance of involving communities in these kinds of decisions about data use in Canada, and how there are elements of data use that need to be sped up while others that may need to be slowed down. I'm wondering if we could begin there.
Right. Thanks, Grant, for that question, and to my fellow panelists, who I will definitely build on comments already made, and to the Royal Society of Canada for the opportunity to be here, because I really enjoy talking about these things, and it's an issue that I'm really hoping that we have an ability to solve now after, as Vivek said, 60 years of trying. So I'm going to start to answer your question by saying why I think it's important to involve communities. And so one of the reasons for that is the quickly evolving world of data. So we haven't even talked about what we mean by health data, but it's pretty clear from the conversation so far that we could be talking about healthcare services use, but in the context of the pandemic, we should also be talking about neighborhood information, race, ethnicity, occupation, all of those other socioeconomic status, all of those other things that maybe strictly speaking, we don't think of as being healthcare data, but they are very, very relevant for understanding health and its distribution across the population. But there's also just, we have Fitbits, we have monitoring systems, we have cars and refrigerators that can talk to us and tell us things. And and I don't mean to be flippant about that, most of those things actually probably have some relevance to some health research related questions and production of health and so on. So all of these things are expanding at this crazy rate. And then at the same time, there's these, and I think especially during COVID, these rapidly evolving conversations about community expectations, particularly around disaggregated data. So now I'm going to talk about the more sensitive data and the fact that they have been used both in the past for good and less good purposes. And, you know, Arjun and Jonathan both touched on that a little bit. So, for example, data use can, and in some cases has absolutely been used or has led to stigmatization, stereotypes that follow people around their experiences in the healthcare system, for example, and discrimination. And I would say as well that the research community has been a bit guilty of being stronger on the descriptive epidemiology part of the use of data and less paying attention to efforts to address the inequities that data reveal. So intervention studies or things that actually try to right the wrong as opposed to just describing the situation. And again, COVID made that really real because, as Vivek noted, perhaps we could have had different policies in place if we had understood nuances of data and transmission earlier in the pandemic. So given the pace of evolution and changing expectations, it's pretty clear that what good practice is likely now extends beyond the minimum requirements of either law or ethics, which are the two kind of basic guiding things for us. And I would include in that ethics umbrella, Ocap and other principles of engagement with communities. Excuse me. So in other words, we have to make values-based or normative decisions about how data should be used, by whom, and for what purpose. And values and norms are not a subject of expertise. So you can't go to a bunch of scientists and say, okay, so how do we enact these things? Where or what are they? This is something that we actually need to have informed by people and communities who are represented in the data that we use. And this is particularly because in the health data space, we're talking about personal data about people and communities and so on. So I would classify this as a necessary exercise of civic engagement and part of our commitments to being a democratic society. And perhaps to use Jonathan's word, this is part of our getting our house in order. So then on the speeding up and slowing down part of your question, I'll just use I'll reflect on my understanding of the existing literature on public use about data use. So on the one hand, it's pretty clear in every engagement that I've read about or have been part of that it involves the public, that there's an assumption that we are doing, and the public wants us to be doing a lot more than is actually currently happening. And I think this just amplifies some comments that have already been made. So for example, everyone assumes that we're sharing data for the provision of care, or is disappointed to find out that we're not. But equally, people assume we're using data to improve services, to make overall care quality better, and as Vivek described, to understand the novel virus and vaccinations and so on. So more important than assuming these things, the public supports these activities as long as they're done with controls and oversight. So in general context really does matter. So this is the part I think we need to speed up because the messages are clear. It's very consistent across publics, across countries and so on. So if we could just understand the guardrails correctly, we should be able to make a whole bunch of things happen. On the other hand, it's also pretty clear that there are some concerns, for example, where there's private sector involvement. What does that mean for data and or where there's more sensitive data in play, whether that means about race and ethnicity, about sexual orientation or gender identity, or frankly about smaller or rural communities where the risk of re-identification or stigmatization is just a bit different than it might be in urban areas. And so to be clear, the public views are not that things are forbidden, but that there need to be different considerations and different guardrails when we're talking about more sensitive data, and particularly the data that have been used to harm in the past. So this is the part that we need to slow down, not stop, but slow down. And then I'll close by saying that current legislation really focuses on individual rights and privacy, but data are far more relational than that. So data about me also says something about my family, and it says something about the multiple communities to which I belong. And so as we think about updating our approaches to data, we really need to be more explicit in acknowledging the social and relational, as well as the individual aspects and protections of data. I'll leave it there.
Thank you so much. Yeah, it reminds me of what two words Vivek was talking about. And Vivek, I wanted to go back to you on this. Two words you mentioned in your opening statement about stewardship and custodianship. I wonder if you can elaborate on that, because I understand when the expert advisory group comes out with its next report, which I think is, I think in the coming weeks, I think those two words are going to play a big role. I wonder if you could elaborate on the concept of stewardship versus data custodianship.
Sure. And if I may, maybe I'll start with an example, because I don't want people listening to us to say that everything's been terrible. And, stewardship is about ensuring we use the data to improve, in the health world, improve people's lives. So it's either using data to improve the care of an individual there as a patient or their family members, or the collective, as a society as a whole, protecting their health, or using the data to do research or develop innovations that will be future information that will help improve their lives. So I would like to give an example from the pandemic that builds on something that Arjun said, where we used data very effectively to make a very meaningful and quick policy change. And it's from Ontario, from the early period of the vaccine rollout. One of the things that was observed was that in the very early stages, vaccination rates were really high in the communities that were least affected by COVID. And not surprising, because the places where vaccines were available, the people that knew how to navigate the complex booking system that Ontario had, and so on, tended to be people in wealthier neighborhoods, and they had lower rates of COVID. And so there was an amazing graphic presentation done by the team at the Institute for Clinical Evaluative Sciences that showed the relationship between level of COVID in a neighborhood and level of vaccination and age groups. And, in one image, you could just see that very clear disparity. And that was released just as the province was going to move to stop having extra doses of vaccine go to the most in need communities. We were saying, we've done that for a few weeks. We're going to now make it equitable on a per capita basis across the whole province. And with that graphic coming out, released by the Ontario Science Table, the province had to change tact very quickly and say, we're going to continue to distribute vaccines. And now, with the booster dose program as it's coming up, they've been very deliberate for saying, okay, these are the communities in which we have to get our clinics out first. And so to me, that's an example of stewardship, using the data in a meaningful way to help bring about the change that communities need to see happening. And so the difference between stewardship and custodianship is, as has been referred now several times, under existing legislation, the titles are different across the province, but there's legislation for protection of health data. Health information custodians are designated. It's often confused as being the owner of the data. They're a custodian of the data. Really, from my perspective, the owner of the data is the individual from whom the data is generated, right? But there's a custodian because someone has, as you get a collection of data, and the mandate that they're given is protect the data, right? And protect the privacy of individuals. And that's the hurdles then when researchers like Arjun go to get the access to data. And, I'm a health information custodian in my role, the executive head of an institution that holds health data. University of Waterloo holds health data in its clinics. I'm the custodian. It's delegated to someone, a privacy officer. But if a request for data comes in on my behalf, that person has to protect the data. That's what, and every hospital CEO, every physician, everyone that's given that mandate of being a health information custodian, that's what the law tells them to do. And so most of the times when someone's going to come to me with a request for that data, I'll probably have to say no, or I'm going to have to put a lot of hurdles up, which leads to the year that Arjun described getting access to data. What we mean by stewardship is let's build into that framework a concept that you are a steward of the data. You have a responsibility to protect privacy, but you also have a responsibility to ensure it's used for the greater good. And we can build other concepts in there. And obviously there's a balance there. It's not easy to be a health information custodian or a privacy officer. And particularly when we start to talk about the kinds of data that we're talking about, bringing together data from public health, from the clinical system, from research, there's actually different legislative paradigms, research ethics boards and the requirements under the Tri-Council policy on human subjects. That privacy officer has to know all these different things. And so the other part of what we're going to be looking at is we have to support people in making these kinds of decisions. And we have to support them in navigating what kind of data that they're working with. So, for example, if you're a researcher, you assume that everyone works under a research ethics paradigm. But if you're in public health, you actually work under the public health legislation of your province. And if you're a clinician, you're working under the health privacy legislation. And if you're dealing with non-health data, if it's electronic data, you're working with this piece of federal legislation called PIPEDA, right? So it's a very complex environment. Not all the data is falling under one framework. And so really supporting people in using data and making those decisions. And I'll just close by saying, because often we want to demonize people. And, I'll often hear, we just have to get the privacy officers or the information privacy commissioners to change what they're doing. They're the holdup to all of this. And I think it's a very simplistic sort of approach. And, we've got one of the provincial privacy commissioners on our expert group, and we've met with all of the privacy commissioners. They want to help. They don't want to be seen as the holdup. And most privacy legislation in Ontario, the general legislation, freedom of information and protection of privacy. And as a journalist, you're very used to using the freedom of information part of that, right? Because it's actually it's about getting the information out there. And we have to bring that concept into the health legislation as well.
Great. Kim, I think you want to jump in here. I wanted to throw it to you because you probably have some good examples of this.
Yeah, I'm just listening to Vivek talk about that. I wanted just to relate a quick anecdote from one of the public deliberations around data use that I was part of. And we were asking the questions about when is it okay to link multiple different sources of data together? And the question comes about because you mentioned something earlier, Grant, about could we anonymize data, de-identify it, and then just make it more freely available. But as you link more and more different kinds of data sets together, you get such a depth of information about people that actually is quite hard to guarantee that data have been de-identified. So you have to have other layers of protection around it. And so we were talking about data custodianship and data stewardship, and the public participants started asking us these questions like, who are these people? Do they have a common job description? Do they have training? Is there certification? What kind of supports do they have? Because they recognized the power and control that that group of people has, either to speed up or slow things down. And all of us were so I'm impressed at how quickly and to the point the public got in asking questions, and I had to answer no, there isn't. It's often just somebody gets tapped on the shoulder and asked to take on the privacy role and might have a little bit of training, but nothing that would be common across organizations or across the country.
Well, we're talking about examples here. Jonathan, I wondered, you mentioned in an earlier conversation how First Nations communities are missing important pieces when it comes to health data. I wonder if you can walk me through a few examples of what you see are missing pieces that, that hopefully can be fixed.
Yeah, so I was telling the story about the genesis of what we call the First Nations Regional Health Survey. And so that story, I'll expand a little bit on that story. So, you know, over the years, as First Nations have asserted or attempted to assert their rights, and sometimes to poor success in the past because of barriers put up by the Crown or a province or a territory. In the case of that moment in the mid to late 1990s, Canada decided to leave First Nations out of 3 population studies. You know, for communities that are facing a dearth of information already, this was an incredible blow. You know, while we might not have appreciated the way the data was being collected, it was not led by First Nations, was not led with First Nations priorities in mind. It was at least information. So to be left out was this incredible challenge. Now, they turned that into an opportunity. The leadership of the day, including the thought leadership of the day, turned that into an opportunity and negotiated ultimately what we now have as this cross-sectional survey that, as I said, is approaching 25 years. But First Nations fall into a lot of gaps. And a lot of this comes down to jurisdictional issues. When I talk about the idea of an information governance regime or the lack thereof, COVID underscored this reality. You know, I think better than we could have without this crisis. You know, at our doorstep. So when COVID hit, you know, Indigenous Services Canada, which of course is, you know, formerly the Indian Department, Indigenous Services Canada, holding a lot of case data, or what would be case data, had approached us, the national organization, to say, you know, can we work with you to explore FNIGC being a steward of this national data? And we said, well, you know, within the frameworks that we've built, yes, we can explore that with you. And here we are, all these months later, nearly 18 months later, still trying to work out the agreement to do that, right? So these are the kinds of challenges that First Nations face. Now, I'm very pleased to say that some of our First Nations partners in different jurisdictions, Manitoba in particular, Ontario in particular, have made some real strides, and it's because of the infrastructure that they've been able to build within that, in these cases, provinces, right? So Manitoba First Nations and the government of Manitoba, and in our case, the Chiefs of Ontario, our partner in Ontario, working with ICES, which was referenced earlier, right? So they developed this unique relationship to essentially wield a mainstream or a Canadian institution to do the work that they need to do. And to ICES's credit, right? They did some of that pivoting that I was talking about to be the best partner for First Nations. Now, we can acknowledge that there's a lot still to do, but it's these gaps that First Nations fall into, and where First Nations are not, you know, leading, setting their own priorities, it means that priorities are being set by others. And so, you know, whether it's information at the level of individuals or information at the level of communities or nations, or even regions where you can point at a map and say, these people have high rates of diabetes or whatever the case may be. That there's a long history of that being done by non-First Nations researchers not working in meaningful ways with First Nations. And it's this deficits-based approach, right? And so it's not based on the values of First Nations from their distinct worldviews, which would be strengths-based, right? That's what the elders we work with, the knowledge holders we work with, the leaders that we work with tell us is, you have to do this work from a strengths-based perspective. That doesn't mean we don't ask all of the important, very difficult questions, but it is a different paradigm. And it's a paradigm that, you know, First Nations were long not permitted to bring to the fore. And so that's when we talked about the systemic change that needs to happen. this data governance strategy that we put forward is that. Now, I know I didn't precisely answer your question about specific examples, but in the interest of time, I wanted to flag that specific COVID experience and identify that still some challenges there, while there have been some successes. But we wouldn't have had the same level of challenge if the work we're proposing to do, going forward, had been done 10 years ago, 15 years ago, or 20 years ago.
That's well said. The delays are surprising. On delays, Arjun, on the research side, I have to admit I'm a bit of a privacy advocate. I believe that privacy is something we need to really guard closely in the times we live in, with things that are happening to our data from businesses and on the commercial side. But I was really surprised to hear you talk about in a previous conversation the delays you face, and the example you gave, which I wanted to get you to talk a bit about, is about the speed that U.S. researchers could get data and do work with it during COVID-19 that, for example, you and your colleagues could not. That really was an eye-opener for me.
Yeah, so I think I agree with you. I mean, I think privacy is a huge issue, and I think consent and control and all of those things are really important. And yet I think these issues are important as well, because I don't think what we want is to create a data environment that's so prohibitive that we actually don't make use of the data. So I don't know exactly what the origins are of this. I don't know if any of my fellow panelists have more of a sense, but somehow there has been more of a publicly available data kind of culture that's developed in the US and to some extent in the UK as well. This is all anonymized data, health and other data. One way to put it is that the holdings that Statistics Canada has, for example, in Canada, that require you to go through an application process and to sort of analyze that data in person in one of their centers, is data that in the US is downloadable off the internet. And so it just creates a very different environment. And I'll tell you, from the perspective of health equity, I think there's much less that we know about some key populations in Canada by virtue of the fact that it's difficult to get a hold of the data and work with it. So I've been kind of very surprised. It's not my field, but I've been very surprised how little systematic population level work there is on Indigenous health. There tends not to be very much on racial health equity, even on socioeconomics that are more common. It's not easy to get that data and work on it. So again, these take lots of applications and time and scheduling, and having people go through a rigorous process to be admitted into stats can data centers and so on. And again, I'm not sort of suggesting that none of that should happen or that it's useless. I'm just saying that from the other perspective, I do think there are some issues that might need to be worked out in terms of how readily people can access the data. I think the only other thing to say about that sort of issue of delay is that I think it makes it so that some things just don't get studied very much. So I think what we risk is just not knowing much about a whole bunch of things that we probably should know more about. And I think, it's just kind of, it's a little bit alarming that we have so many gaps when we probably don't need to have those gaps to the extent that we do. One other actually thing that I might add that I'd love to hear, my fellow panelists chime in on, the point about stewardship and making sure that we're using the data to improve individual or collective health, that makes a lot of sense. What I'm a little bit sort of interested in, at least, is the direction that's taken in terms of getting access to health funding. So getting access to health research funding. So in many ways, the way that that seems to be interpreted is that the data should be used, I think to Kim's point, the data should have some immediate intervention possibility, or that's often what people are looking for when you go to granting agencies. So people, especially, it's quite interesting. So if you propose health equity work, the assumption is that whatever you're producing in terms of your research should have some fairly immediate application, some connection to some intervention that some organization or some community is going to kind of shepherd through or sign on to in one way or another. Part of the issue is that some of these health inequities are produced by such fundamentally sort of social structural issues that they're not amenable to sort of public health or health system intervention changes at a small scale. And so one other issue I think might be how we are perceiving or operationalizing how to do good with the data. So I've been asked this in radio interviews and TV interviews and so on during the pandemic. You know, do you think that this data is going to do any good? If we collect race data, can you tell us that tomorrow or at some point in the foreseeable future, things will improve? And actually, I cannot. I don't think I could ever say that the data is going to translate into change. It's unclear, and maybe it will down the line, but it's, I think, dangerous to use that as a threshold. I think we still need to know what's happening in our society, irrespective of whether we think we can intervene in the immediate future in ways that will change things, because those interventions are political. It's just very difficult for a health researcher to influence income inequality. You know, like these are yardsticks that I think we have to think really carefully about in terms of how we think about what's useful data access and not. And I think the goal of understanding how our society looks, what's happening in our society, giving the public access to that information, hoping that that enters the discourse in how policies are designed, that's a worthwhile goal, independent of whether, as a researcher, I can say to you, yes, this data will, you know, produce a change in policy, which it's impossible to know that.
Well said. We've got a few minutes left. We've been critical up into this point about what the problems are. I want to throw it open, and there's not enough time to really go deep into it, but what are the fixes?
Maybe I'll just start off and say that I think it goes back to what I opened with, and this is what we'll be focusing on in the expert group's work, is looking at the more fundamental issues, and that's on ensuring there's accountability and clear governance, there's community citizen engagement, and there's work on the policy frameworks before we jump to looking at the systems and standards. So that's all important work, but that tends to be where we go to. Arjun just mentioned the importance of political leadership, and it's the same as dealing with inequities, dealing with these challenges which have been with us for so long, which are based in political considerations and our constitution, split of powers between the federal, provincial, territorial governments, the role of engaging First Nations, Inuit, Métis communities to build their data strategies. And I really like the way Jonathan framed it as, you know, we shouldn't take all the deficits that we've put in the Canadian system and hand them over. We have to fix those, and in collaboration. I think the message is that it's going to be a lot of hard work, and it's going to take leadership and will. But I do hope that coming out of the pandemic, with the attention that we have with people like yourselves and the media, as well as the public at large, that motivation is going to be there.
We have time for one more thought if anybody wants to jump in.
Maybe I'll just jump super quickly to say that data access currently is a pretty paternalistic exercise because it is trying to protect perceived privacy rights and so on. And I really believe if we involve communities, and this would include communities of any stripe, in not just in allowances for data access, but in telling the stories that come from the data so that they are stories of strength and not stories of stigma, that would go quite a long way to addressing some of the things that others have raised.
Great. Well, that brings us to the end of our time today. I want to thank all of you for joining us today. It's such a great panel, and it's great to be able to see your work on this subject. And thank you to the audience for joining us today.